This video on techniques in nerve reconstruction and repair was prepared by Liang Chen and Martin J. A. Malesi to accompany their chapter in the Yeomans and Wynn Neurological Surgery textbook. In this video, we will expound various nerve repair techniques after review of functional anatomy and explanation of pathologic and surgical principles of nerve injuries, and lastly, envision research prospects of how to improve surgical results. We hope that after watching this video, you will be able to understand the indication and method of various nerve repair techniques, as well as the research prospect of how to improve surgical results of peripheral nerve injury. There are external epineurium and internal epineurium for the nerve. Epineurium functions mainly as a barrier against outside stresses. Perineurium mainly functions as a blood-nerve barrier that physiologically helps maintain a stable milieu for nerve fibers. Thus, in decompression operation, the perineurium should not be breached. Normal endoneurium looks like a gelatinous material. The arrow in the photo points to a healthy section with normal endoneurium bulged out. This section is a precondition for successful nerve repair, as an attempt to oppose the proximal and the distal stump with scar always results in repair failure. The nerve fiber is the axon with its enveloping Schwann cells. This component is further enveloped by the basal lamina. Schwann cells have a complex homeostatic relationship with the axon, and they also play a critical role, together with the basal lamina, in nerve regeneration. On the other hand, there has been a study indicating that the undulating architecture of nerve fibers was the first element destroyed by stretch, and this undulating characteristic and endoneurial fabric are important elements to resist traction force. However, if the nerve trunk is stretched by 20% of its length, which exceeds the tensile strength of the nerve, it is almost certain to suffer a discontinuity. Although there are extensive microvascular interconnections within the nerve trunk, the surgeon should do his best to protect extrinsic segmental vessels. For example, in surgery of cubital tunnel syndrome, transposition of the ulnar nerve anteriorly has the potential hazard of damaging the segmental nutrient vessels, resulting in devascularization of the ulnar nerve. This is a serious complication that can induce causalgia and even paralysis. The arrow in the photo points to the inferior collateral ulnar artery that should be protected during anterior transposition of the ulnar nerve. The neuropraxa in Seddon's classification is conduction block with no Wallerian degeneration. Spontaneous recovery is usually complete if the cause of injury is eliminated. Examples of this lesion are that caused by overlong use of tourniquet and Saturday night palsy of the radial nerve, which often results from alcohol-induced deep sleep. Axonotmesis interrupts nerve fibers with sometimes disruption of basal lamina and endoneurial tubes. There occurs Wallerian degeneration. Complete spontaneous recovery can only be expected if basal lamina are intact. Neurotmesis means actual disconnection of the nerve, which necessitates operation. Most closed peripheral nerve injuries are neuropraxia or axonotmesis. Patients should receive monthly clinical and neurophysiologic evaluation for 3 months to seek evidence of nerve recovery. After that time, in patients with no improvement in sensibility, muscle strength, and neurophysiologic test results, and with no progression of the Hoffman-Tunnell sign, and after evaluation of findings in magnetic resonant imaging and/or ultrasound imaging for them, surgical exploration is warranted. In general anesthesia, due to use of nerve stimulator recorder, only a short-acting muscle relaxant is used for induction. Some surgeons prefer a bloodless field. It must be realized, however, that tourniquet use introduces a variety of risks. An absolute contraindication is a limb with arterial prosthesis. For patients with rheumatoid arthritis, diabetes, alcohol addiction, tourniquet dimes must be reduced or use is avoided. Also, overlong use and use for older patients may worsen postoperative pain. For simple stimulation with observation of motor response for the purpose of locating, identifying, and protecting nerves, the simplest stimulator with uni or bipolar can be applied. For intraoperative nerve conduction studies to evaluate lesions and their proximal continuity with the central nervous system, elaborate apparatus is needed, say electromyograph evoked potentials equipment. As to microsurgical technique, the elements are merely application of fundamental surgical skills. They are gained by practice. For magnification, we apply loops with magnification of 2.5 times for most of operations on adult patients, whereas magnification of 4 times is more appropriate for infants. The microscope in our unit is applied to operation teaching. A range of sutures should be available. 9-0 or 8-0 monofilament nylon is used for epidural suture. 9-0 or 10-0 is applicable for fascicular suture. The repair site may be reinforced with fibrin glue. In some nerve grafting situations, fibrin glue can completely replace sutures. In a clean-cut wound, 1 millimeter of resection may be enough for a damaged stump. In a traction laceration caused by blunt injury, say a fracture, 5 to 10 millimeters of nerve resection is required from either end for displaying normal nerve bundles. We prefer immediate repair after debridement, as early repair conduces to functional recovery, and also it is far easier to do this immediately than to repair the nerve in a later stage when extensive scar tissue may need to be traversed in order to expose the retracted ends of the divided nerve. For exposure of an old lesion, the dissection always begins by isolating the normal nerve proximally and distally, and then proceeds toward the zone of injury. Sometimes the most severe scarring zone can be left in situ to avoid damage to neighboring structures, and nerve grafting is then performed. This photo shows isolation of a median nerve that had been repaired, together with anastomosis of the lacerated humeral artery months earlier but had no sign of recovery. We left the most severe scarring zone and grafted the nerve. After isolating the nerve lesion circumferentially, that is, an external neurolysis is completed, neuromas can be identified. The neuroma having 2 swellings means a complete rupture that necessitates nerve reconstruction. For neuroma in continuity, if there is no intraoperative compound nerve action potential detected, it warrants resection followed by reconstruction. Direct neurorrhaphy can reduce loss and misrouting of axons that have crossed the repair site successfully as compared with nerve grafting. However, the excessive tension should be avoided. If a single 8-0 nylon epidural suture can keep the apposition of the proximal and distal ends in an anatomic position, no undue tension exists. Mobilization of stumps for a few centimeters can relieve tension. Anterior transposition of ulnar or radial nerve gives 3 centimeters at most. Flexion of joints followed by immobilization for weeks is also a method of overcoming the defect. This is especially true of sciatic nerve defect to which autologous graft material is often insufficient. Because this maneuver runs the risk of destroying the neurorrhaphy during later mobilization and of inducing stiffness of joints, in principle it should be applied only infrequently. In general, nerve grafting should be considered for gaps more than 1 centimeter in length. Clinically, end-to-end neurorrhaphy is unlikely for lacerated brachial plexus above the clavicle, spinal accessory nerve, and median nerve in the forearm. Epidural repair is still most commonly used. Here is a video showing epidural repair in spinal accessory to suprascapular nerve transfer by a posterior approach. After trimming stump ends to show the healthy section, the epidural edges of both ends are sutured under surgical loop or microscope with 9-0 monofilament nylon. The second suture is placed 180 degrees apart. Other sutures are added on the anterior and posterior sides. The repair site is checked to correct any disturbance. Fascicular repair is to suture fascicle to fascicle through perineurium. It has the theoretical advantage of maintaining the specificity of the fascicle, but no persuasive clinical trial proves its superiority to epineurial suture. Fascicular repair is mainly indicated in three situations. One is in repair of the median nerve at the wrist, where fascicular repair is performed on the motor component innervating the thenar musculature. Another is in the Oberlin operation, in which one fascicle from the ulnar nerve is transferred and sutured to the biceps bundle of the musculocutaneous nerve. The third is in nerve transfer procedures, where the donor nerve is much finer than the recipient nerve. In grouped fascicular repair, a group of fascicles is used as a suturing unit, with otherwise the similar principle to fascicular repair. Internal epineurium or perineurium is sutured for the two groups of fascicles. One indication is median nerve injury in distal arm, where three fascicular groups are well clustered. The other is injury with continuity of only a subset of fascicles maintained. In that situation, the remaining interrupted fascicular groups are repaired with the grouped fascicular repair after internal neurolysis. End-to-side repair is a type of neurorrhaphy involving the coaptation of the distal end of an injured nerve to the side of a neighboring normal nerve. There are two suggested mechanisms for axon regeneration in ETS repair: terminal as well as collateral sprouting from the nodes of Ranvier of the neighboring healthy nerve. The reverse ETS repair is to coap a transected, uninjured motor nerve to the side of an injured nerve. There are two main clinically reported indications of ETS repair. One is a nerve lesion in which the proximal stump is not salvageable, and the reverse ETS is used as an adjunct to proximal lesion where primary nerve repair is performed. In this situation, the reverse ETS plays the role of supercharge with the aim of obtaining augmentation of reinnervation. On the whole, however, the role of ETS is debated, and the clinical effectiveness of ETS neurorrhaphy has to be further verified. Autologous nerve grafting remains the gold standard for treating nerve defect. Defect length is measured with extremity in full extension or shoulder in 90 degrees of abduction. Technically, there must be no tension at both repair lines once an autograft is in place, so that the graft length should be at least 15% in excess of length of nerve deficit. Usually several segments of donor cutaneous nerves are required for bridging between two stumps. In cable grafting, which we use in most cases, the cross-section of the host nerve should be covered as fully as possible. Most often, 3 to 12 strands are required. Grafts are placed one by one or sewn together in advance in areas of deep or awkward anatomy. In interfascicular nerve grafting, individual nerve grafts are used to bridge the matching fascicles or fascicle groups at both stumps, with interfascicular epineurium or perineurium sutured. It's most useful when autograft sources are lacking. For example, in a traction lesion of the median nerve, the defect may sometimes be more than 20 centimeters long. Two strands of sural nerves are then used to graft elements from the lateral root of the median nerve to the middle fascicular group of the median nerve in the distal arm for improvement of hand sensibility. When nerve defects need longer grafts for reconstruction of motor function, say those of more than 20 centimeters long, vascularized nerve grafting may be performed. Examples are application of the pedicle or free vascularized ulnar nerve graft in contralateral C7 transfer or an ipsilateral viable C5 grafting for reconstruction of the injured brachial plexus. Clinically, the sural nerve is most commonly used for grafting because the injured sural nerve has a tendency to form a painful neuroma. The proximal end of the nerve should be implanted within muscles or beneath the fascia in the proximal calf if only a short length is required. The sural nerve can also be harvested by endoscopic technique with only 2 small incisions needed. Here is a video showing cable nerve grafting with sural nerves for a case with median nerve defect. Strands of graft material are interposed one by one, with the epineurium of the graft coapted to the epineurium of the host nerve. The other half strands of grafts are coapted to the back of the host nerve. At the distal repair site, suture of nerve grafts begins at the back of the host nerve. After repair, the suture lines are inspected to correct any disturbance. Synthetic tubes made of bioabsorbable material can provide a chamber with neurotrophic and neurotropic factors from migrating Schwann cells and nerve stumps, for axons to regenerate and to be guided into distal endoneurial tubes. Studies have confirmed the ability of those tubes to support axonal regeneration in human beings. Until now, however, none of the tubes have been shown in surgical efficacy to be superior to nerve autografts. The progress toward improving outcomes of motor recovery after nerve repair has been limited till now. Many factors influence operative results. Studies have indicated that better recovery in children may be mainly related to higher potential for brain adaptation to peripheral nerve injury. It is generally thought that operative delay of more than 6 to 12 months is an unfavorable factor. And so, when the surgery is indicated, the earlier the operative timing, the better results. The proximal level injury and graft length greater than 5 centimeters are another 2 unfavorable factors influencing surgical results. Now prospects for improving surgical results are envisioned. Clinically, nerve repair can fail due to denervated muscles having reached a state of irreversible atrophy. Thus, elucidation of self-regulating mechanism of denervated muscles may help delay the progress of muscle atrophy. On the other hand, some researchers have indicated that failures of nerve repair may result from progressively ineffective growth-supportive environment of the distal nerve stump with time and distance, and from progressive decline in regenerative capacity of axonatized neurons. Thus, development of a neurotrophic factor gene therapy and of stem cell application for patients with proximal nerve lesions is one of the strategies to overcome the aforementioned unfavorable factors influencing nerve regeneration. Studies have shown that efficacy of neurooraphes is positively correlated to the potential for central nervous system to adapt to peripheral nerve injury and early sensory and motor relearning with cortical reorganization techniques have been reported to improve result of nerve repairs. And so further elucidation of the mechanism and influencing factors for cortical reorganization is necessary to obtain the best rehabilitating results after peripheral nerve surgery. To summarize, since the 1970s, advances in microsurgical techniques, improvement of apparatus and instruments, and progress of basic theories of nerve regeneration have enabled surgeons to treat neuropathic nerve injuries by using direct nerve repair, nerve grafting, or short-length artificial biodegradable conduits. Although direct nerve repair is the method most frequently applied clinically, nerve grafting is important if there is a potential for undue tension at the repair site. For improvement of surgical results of nerve injury, further studies should be focused on delaying atrophy of denervated muscles, improving regeneration environment in the distal stump, and intrinsic regenerative ability of neurons, and altering the interaction of peripheral nerve injuries and functional remodeling in the central nervous system. Thank you very much for watching this video on techniques in nerve reconstruction and repair.